running a few minutes late as we are still aligning with some of our panelists to make sure that she or they can participate with us this afternoon. I'd like to start off by welcoming Mike Damiano, who is the Chief Executive Officer of the Allegheny ARC, and he's going to be walking us through the first portion of the webinar this afternoon, which is on the collaborative of the Finger Lakes and Western, and what it is, what it isn't, and just the general structure of the collaborative. And then the second portion of our webinar this afternoon is on the New York State START program, and we have several speakers that are going to be outlining that program. We will be taking questions via computers, so please feel free to type in any questions and we'll certainly address those as each speaker finishes. And I'm going to go ahead and turn over the presentation to Mike so that he can give a summary of the collaborative. Thank you, Mike.
Great, thank you. So the Collaborative of the Finger Lakes, we are a 501c3 not-for-profit corporation. And I'm still looking at the first slide here, so we can go ahead and advance. Okay, and we're organized together to make sure that we have the most innovative management supports for the people that we support. On the map here, you can see just briefly the area of the state that we represent. And on the next slide, you have a list of all of the counties that are included in the collaborative today. Those counties would be Allegheny, Genesee, Livingston, Wyoming, Ontario, Schuyler, Steuben, Chemung, Monroe, Onondaga, Orleans, Seneca, Cayuga, Wayne, and Yates. One of the things that makes the collaborative unique is that all of the members of our group are NYSARC chapters. We don't have any independent providers or any other type of DD organization included in our membership. The next slide is just kind of a blow-up of the map so that you can see how much area we cover and how our counties are geographically oriented to each other. You can see that Ontario is kind of the geographic center, and that's where a lot of our activities occur. So about our board of directors, one of the things that I think is unique about the collaborative is that different than the way trade groups operate, each of the executive directors from the member agencies comprise the board of directors, and membership starts really with a commitment that each director will attend every meeting. We meet the first Friday of each month, and I kind of like to think about it as a Catholic school kid, we were expected to go to church on the first Friday of every month, and the collaborative is kind of like that. So we all make that agreement, and unless somebody's on vacation or really ill, we make sure that we're all there. And you can't delegate attendance to anybody else from your agency. Only the executive directors can participate at the board. Board members also agrees to serve as an executive sponsor of one or more of our strategic and or project and networking teams. And I'll kind of tell you a little bit just about the ongoing projects, and then we'll talk about the strategic teams. On the next slide, you'll be able to see a list of some of the ongoing projects. The Arts Experience and Gala, this happens in the spring each year, and it's a week-long collaboration at Hobart and William Smith colleges, and a series of participatory events are put together for consumers from all throughout the region. with different art, performance, and other types of art activities. And it's ending with a gala on the Friday night. We have a self-advocates team and an annual self-advocates conference. And I always have to say how proud I am right now. My son Joe is the chairperson for the collaborative self-advocates team, and they put a very nice conference together every year. We have a management information systems team, the Work Matters team, which focuses on employment issues, the annual DSP conference, also a supervisory series for management level people, and most of that training is provided by people in management and supervisory roles throughout the member agencies. And the last is shared training. So we have a training team. The collaborative entered into a contract with Relias Learning Systems, and all of our training staff come together and try to identify and pick the best curricula from all of the agencies, or develop the best out of pieces from each of their curriculum, and put it together on an online platform where all of the agencies can then benefit from it. The next slide, you see some information there about the arts experience that I just mentioned. The collaborative does have a web page that you can go to if you'd like to look at some of the information there. So going to the next slide, we'll talk just briefly about the collaborative strategic priorities. I think it was October, November of the past year, we came together with an outside facilitator and really thought about what our strategic destinations should be as they relate to our future in a managed care system. So these 4 areas were the ones that we chose to really focus on: quality systems, workforce sustainability and development, care coordination, and value-based payment. So as far as quality systems are concerned, we want to assure that all of the member agencies meet or exceed all of the standards that we have to answer to. And going to the next slide, and one more after that. There we go. So we had an agreement, I think, about 2 years ago that all of us would achieve and maintain CQL accreditation. I think everybody has at least their initial accreditation at this point. And right now we're working on an inventory of all the applicable quality standards to try to put together a comprehensive tool so that we can see where each member stands, whether it be NYSARC's quality indicators or the collaborative's quality framework or CQL indicators, or others, OPWDD indicators. And we'll use that to develop acceptable standards for all of our member agencies, and then try to incorporate those into a value-based payment system when we're ready. As far as workforce sustainability, the next slide, we try to ensure that we have sufficient and competent DSPs and management staff. And really, this is about, right now, sharing best practices, social media, staff incentives, tuition programs, to try to attract staff that we can find. You can go to the next slide there. Also to share best practices related to retention of employees, and also to identify staff development strategies that could be offered more effectively or efficiently through the collaborative. Next slide, care coordination. This is the team that I'm one of the 2 executive sponsors for right now. As many of you are aware, the Office for People with Developmental Disabilities is responsible to provide a plan to the Center for Medicare and Medicaid Services in October about how they will deliver conflict-free case management in the DD system. So we want to be in a position to influence some discussions in Albany and hopefully either ask some questions that OPWDD is not thinking about, or to offer some solutions about really maintaining as much as we can about person-centeredness rather than a more medicalized model of care coordination. If you go to the next slide, one of our intents would be to benchmark with PHP about what their interim successes are, and hopefully to not reinvent the wheel, but to find those strategies that they've already implemented that will make sense for us up here. Also to retrain or plan to retrain as many of our MSCs as possible to become care coordinators, and then possibly to use the collaborative as a centralized structure to provide care management. Then moving on to value-based payment. So this team is working on strategies that enhance the fiscal and quality services in a value-based payment system. So really what we're thinking about here on the next slide okay, there we go, would be to look at the benefits and risks in forming an organized provider network. What we're talking about here may be an IPA or an MSO. We're not really sure yet, but we're working with consultants to determine what the best business model for the network, whatever it will eventually be, would be. And then to decide if each member agency, what they need to do to get ready for that, and that if everybody is going to enter into that together, or if it may be a stage-wise or step-wise process, and then to identify services that the group would provide, and then develop partnerships and networks in our region. So I see that it's 4:20. And I had about 15 minutes, so that was the lightning fast version of what the collaborative is all about. Thank you.
Thank you very much, Mike. I appreciate you participating today on behalf of all the folks that have dialed into the webinar. At this time, I don't see any questions that have been submitted, but I encourage any of you, as you're considering the information Mike shared on the collaborative, if you have any questions, feel free to type those in. And if we don't have time at the end of today's webinar to address those, we're certainly able to follow up via email to all of you that are participating today. We're going to move on now to the second part of the webinar, which is really focused on something that is connected to the collaborative to an extent, because we are looking at programs that can cover New York State and obviously in large populations, how we implement those programs. So there is a lot of discussion around the START program, and we'd like to welcome 3 speakers today, led by Gary McIntee of the Western Finger Lakes START program. He is the START director, to talk a little bit about the Western Finger Lakes New York START program and across the New York State initiative. So I'm going to turn it over to Gary to walk us through that program. Gary, are you on the line? I think your phone may be muted, so I would just need you to unmute your line. Okay, we may have a little technical difficulty going on right now having Gary connect to the webinar, so I'm going to go ahead and put myself on mute while we take a moment and see if we can connect with Gary another way. Thank you for your patience. Please hold.
Turn that up. Can you hear us now?
Yes.
Yes, we can. Thank you very much. I just
It's over.
I'm going to go ahead and mute myself so we can prevent some echoing and turn it over to Gary McIntee. And again, I appreciate everyone's patience with some technical snags, and we look forward to hearing more from you now on the New York START program.
Yes, and one of the things we've learned at being a very mobile agency that we do have technical issues once in a while. We're getting better at it though. So anyways, what we have is a PowerPoint presentation that we have worked with OPW on. They keep things pretty much up to date for us. I'm Gary McIntee. I'm the regional director. And as Mike was saying earlier, the collaborative is a key factor in our essence, essentially. We actually cover all the way to the Lake Erie border in Region 1 of OPWDD. With me today, I have Jill Hinton, who has been our mentor and coach all along the way. She's been involved in the START initiative in New York, I think, from its very beginnings. And we also have Pam Overdurf from the Arc of Chemung. She is part of the management team that assists us in developing this program in Region 1. So at this point, I'm going to let Jill go into some of the first slides of the PowerPoint.
Thank you, Gary. So, yes. So we are using some slides that, as Gary mentioned, that the state has put together and we kind of collaboratively work on. So as you know, the developmental centers are closing across the state, so OPWDD wanted to make sure we had effective community-based models. What I will say from that perspective, as Gary mentioned, I'm with the Center for START Services and have worked in several states in developing START programs, and I feel like you're very fortunate here in New York that the state is really committed to developing this model. They have financially and otherwise really made a commitment that this is going to be an effective service in the community. So it's been really nice to partner with New York State in developing this program. So essentially we're trying to, across the state, develop a consistent model that provides crisis prevention and response and intervention to folks that have dual diagnosis, both IDD and mental health challenges. And we do that through partnering really with other parts of the system. You'll hear a lot about that later. We really work hard to create linkages and work with other programs and other settings within the community. Okay. Next, thanks. So kind of a background. These are probably all familiar to you, but basically, in many states, in New York and in many other states, the crisis responsibility for individuals with IDD and co-occurring mental health and behavioral health needs has been difficult to be consistent across states. And this, as I said, we see in several, lots of states that we go into that it's been difficult to address the needs of this particular population. It happens for a lot of reasons. A lot of states, have kind of siloed services, so it's hard for people that kind of fall through the cracks to find the right place. people have a lack of understanding sometimes of that dual diagnosis and how to address that. And so there's just variabilities across the state in terms of how folks are provided service. I'm sure there's some areas where there's been pockets of places where there's been some good services to this population, but then other places where there's been a struggle to try to meet the needs of this particular population. And with some other things happening in your system, like facility closures, it's a good time to try to look at how we can fill that gap and try to meet those needs. Next slide. So again, why start? The state of New York really, I think, investigated, looked around to find out what model they thought might meet their needs. And START was one of the ones they looked at. And so they chose that one because it seemed to be the one that would ensure that we try to bring the system together to meet complex service needs. And again, it provides not only the crisis response for those that are enrolled in the program, but also does a lot of more secondary and primary types of prevention intervention so that we're able to address the system needs. The state is seeing START services as one aspect of the safety net supports for people with IDD, which is really critical to building that community capacity as we try to change kind of the structure of the state in terms of moving from more of an institutional capacity to more community-based. So we'll be working within systems, and again, START sees itself as only one part of the system that works to connect with other parts of the system. Next slide. So in 2014, the first two teams were started, two areas of the state were started. So START has been implemented in two geographic regions, one here, Western New York and the Finger Lakes area, and then the other is in the Capital District and Hudson Valley areas in Taconic too, right? Mm-hmm. Yes. So these two teams were the first ones to get started. The START model was initiated using some funds from the BIP dollars, and that they continue to be able to be used to implement the model. And the state's been very resourceful and creative, I think, in the way they've been able to use those dollars. There's also some additional funding that's been allocated from the DD Planning Council. That's been some of the stakeholder engagement and other technical assistance. So again, I can't emphasize enough that the state really has been a great partner for START and has really shown that they're committed to making sure the model is implemented to fidelity. Next slide. So as part of the very beginning of the process, once some gap analysis were done to kind of look at what's going on in both of these first two regions of the state, we worked together to develop a mission for New York START. This is the one we came up with. New York START increases community capacity to provide an integrated response to people with intellectual developmental disabilities and behavioral health needs, as well as their families and those who provide support. This occurs through cross-systems relationships, training, education, and crisis prevention and response in order to enhance opportunities for healthy, successful, and richer lives. And hopefully those of you who may have had contact or had some experience so far with the START system here in New York will realize again that we're really working in a different way than most services have operated in the past in terms of really trying to establish those relationships, really focusing on health and well-being and strength-based approach, so really trying to use people's strengths, make them healthy, successful parts of the community, and doing that through really connecting with all the partners in the community. Next slide. So as I mentioned before, and you guys know, OPWDD Central Office is really overseeing this statewide rollout, making sure that they're providing the type of supports that are needed so that the programs are implemented with integrity and with fidelity to the model. There are liaisons available in each of the DD regional offices across the state, and they serve an important role in connecting to the teams and connecting them back to the regional offices. Again, we want to make sure we're including everybody we can in this partnership as we try to create a START network in these areas of the state. We are moving towards statewide implementation, and that's the goal for the entire state to be implementing the START model. So I mentioned that initially there was some service and gap analysis done to kind of look at the different regions of the state, determine the size and makeup of the teams that would be needed. So things were looked at like population density, the size of the region in terms of just geography, what specific needs were identified in the region through the gap analysis. So that determined how we initially decided how many teams were going to be in each region. Again, that's based on a pretty comprehensive service analysis, but the state has been open to us adjusting that as we've gone and determined that maybe there's more needs in certain areas than others. So we have an initial plan based on the analysis, but there's been some flexibility, I think, as we've rolled out. Within each of the regions, there will be a regional advisory council. Some of you may actually be part of that who were on the call. And as we get nearer to completion of implementing it statewide, OPWD also wants to develop a statewide advisory council. And these advisory councils are an important aspect of how we operate because we really want to, again, make sure we're having engagement with all parts of the system. And they're a place where you bring stakeholders together to review data, to help problem solve, to kind of help guide the implementation and create ways to support the team and also help when there's barriers identified. Okay?
Many members of the advisory boards for the STAR programs come from all sorts of sectors of the human services population. We have law enforcement representatives, we have education representatives, mental health, and as well as many providers of service for people with developmental disabilities. As we work, and there are key people in helping us going forth and work with the various agencies across the area, one of the big pieces that we try to develop is a good working relationship to help people understand what our role is in the community, and it's through linkage agreements with these various providers that forms that framework of understanding and who does what, how we can work with them. One of the things we talk regularly about is how we're here to assist the system, and it's very different than many providers in the past. As the regional implementation moved out, next slide please. We were the first to go live essentially in Region 1. Region 3 was shortly behind us a few months later in October of 2014. And just recently a number of 2 teams have been identified in the New York City area and they are busy hiring up staff and getting their STAR programs initiated. We just ended a meeting with having some representative from OPW, and it's anticipated that a request for application will be released very shortly for the Long Island region. And then Central New York is the last region to begin implementing the STAR program in 2017. As I said, our first opening and taking on individuals and working with the community formally was in August of 2014. Again, it's through the collaboration and identifying the Arc of Chemung as being the lead agency in that collaboration that's helped us move forward. Our team is constantly being evaluated to be sure that we have sufficient staffing and numbers to provide the service in the community. There's myself, clinical director, and just recently we expanded our program to provide service out of 3 different locations and have expanded from our initial 2 team leaders and 8 coordinators to 3 team leaders and 10 coordinators. Our offices are located throughout the region. We're in the West Seneca area of Buffalo, or Batavia, where we are sitting today, and in the Canandaigua area. So we try to keep our teams as close to the various providers we're working with as possible. Again, there's some model issues that we try to make sure we adhere to, and we're going to get into some of those different factors of our program in the coming slides. Excuse me. One of the, and I'll let Jill speak about what the Resource Center really is, but we're happy to know that we're getting very, very close to being able to offer a Resource Center in Region 1.
So as Gary mentioned, part of the model, in addition to the clinical team, and he mentioned the team leads and coordinators that are in those 3 hubs, another part of the model is having a therapeutic resource center, which is a house that has 4 beds that are designed to provide some crisis stabilization for individuals in the system. So this region eventually will have 2 resource centers. As Gary said, we're getting really close to implementation of the first one. And this is another tool for those coordinators that are part of those teams as they work in the community and work with folks who have experienced crisis in the past or maybe currently experiencing crisis. It provides a place for, as I said, a therapeutic intervention and stabilization. So within the house, there's 4 beds. 2 of those are designed for more acute kind of emergency situations. And for those folks that come in, they typically stay around 30 days or so. And that's to help stabilize, do a lot of assessment, provide some therapeutic interventions, and really work on developing systems for that person to go back into their home community. The other 2 beds we use for what we call planned. I know it sounds unusual to call a crisis a plan, but we work with, particularly around families that have individuals still living at home with them. We identify through our coordinators families who would benefit from maybe having some periodic times when that person comes into the center. And these would be shorter stays of like 3 to 5 days. And again, it's a therapeutic environment. It's not just respite. It really is designed for us to learn as a team more about that individual and to help with the family in terms of what they're having to work on at home so that we're able to better serve that individual and that family. So again, this is a critical aspect of the model, but I do want to point out that from our experience and in other places where we've implemented the START program that about maybe 20% of the folks that actually receive services through START access the resource center because in many times we're able to provide other kind of supports in the system so that the person does not have to leave their home or their place of residence.
We've been providing in-home services for over a year now, and actually data is constantly changing. I see on the slide that's picked up about 21 families and individuals, but to date I believe we're over 26 families and individuals that have received in-home supports. And it's also important in that about 50% of those individuals receiving supports have been 18 or under. So that's something that we've been talking about with National regularly and OPW in that we have a significant population of children that we're serving in this area.
Next.
As the Region 3 team, the Hudson Valley team, we've been working collaboratively with them. We've been sharing our experiences. They've been sharing theirs. This is the first team, I believe, in the nation that has been comprised of state employees. They have a similar structure as we do, having a START director, clinical director, and 3 teams. And they're in the process of identifying locations that can be also used as resource centers in their district. And since September of 2014, they've been taking on cases. As yet, I don't believe they have in-home, but that's hopefully coming very soon. And again, the resource center development is still being looked at as far as identifying sites and what's needed to enhance those sites to be able to provide that service. In the New York City area, there's becoming a formulation of teams. I met with some of the managers, the directors and clinical directors recently in Atlanta at a national START conference. There are 2 provider teams being beefed up, so to speak, hired up in the New York City Region 4 area. I'll let Jill, I'm always tripping over the letters for...
Yes, right. So yeah, in addition to working with this team, I'm also working in the city with these 2 new teams, and as Gary said, they're in the process of hiring. They have hired now their START director, assistant. We've added a position, as you can imagine, in the city. It's a pretty large undertaking. So they have a START director, assistant director, and clinical director. Those positions are hired, and both teams have, I think, are close to hiring all of their team leads. So they're underway and getting staff on. The goal there is to begin to take some initial referrals probably in August. So we're doing a lot of training and getting those teams up and going there. This will be, of course, the most complicated, largest place that we've implemented START, so we're learning as we go. But they will be providing the same type of services that are provided here, in this region and in Region 3 in terms of the clinical team trying to find resource centers. We've got one identified maybe for the Richmond Kings area already, and also developing in-home support services. Next.
Within the New York City team, they'll also be developing a multimodal team that will be able to support all the START teams across New York State. This will bring together a number of experts in the field to assist all of us in better understanding the individuals that we're working with, and that any of us would be able to make referrals to that team.
Yeah, and this is designed to be a resource for those cases that different teams may get that are really complicated, complex, that people are kind of stuck with. So this won't be provided to everybody that gets referred to START by any means, but the teams will work internally with their own clinical staff and make decisions about possible referrals to this multimodal team. And we will try, as Gary said, to bring together some experts. It's not a from the beginning, it's like step one assessment. The START teams will be gathering a lot of information and bringing them to this interdisciplinary team of 4 to 5 folks, covering everything from neuropsychiatry to psychology to medical, maybe occupational therapy. So there'll be a group of folks that we bring. They'll see the individual, but also the START coordinator will bring a wealth of information that they've gathered so that we can get another look and a real intense look at some of these cases that are very complex. And really the system's having a hard time knowing where to go next with them. This is very exciting. I think it's been implemented in University of New Hampshire, and it was originally initiated out of UMass. So we're really excited to be able to replicate that here in New York.
A key component of the START program is data analysis and pulling together information about what's happening. In the next few slides, we have data that's been pulled from SIRS, which is a START-based data program, and a lot of the data has helped in implementing the new teams in the New York City area and rethinking the way to enroll START across the state. As being the first region to go operational, we learned a lot about what it takes to provide service in a large geographical area. And we're hoping that some of the things we've learned, some of the things the Region 3 team has learned, will help the Region 4 or 5 and other teams really benefit from our experience and run smoother than we have. Although I think we've run pretty smooth, and that we've accomplished many of the goals very, very early in our livelihood for the program. The next slide shows some basic demographics between the two regions that have been operational. When we look at the programs, we've both been able to provide treatment to a fairly large number of individuals. These numbers surpassed what was forecast for us to be providing services to this early in our program history. The other piece that we've found is the difference, the amount of youth that we've been serving, particularly in our region. And even within Region 1, we're finding that in the western part of our region, the majority of those youth under 21 have been referred to us. And we're still analyzing as far as trying to gain an understanding of why that huge influx. We've been talking to National START as well as OPW about what that means for other START programs that are going to become operational in New York.
As Gary said, this is unusual. The Region 3 was about 35, 36%. That's typically what we see in programs when we have lifespan programs that include both children and adults. So yeah, it's been a little more. That's 37, not 37%. But anyway, it's been a little more distinctive here in Region 1 in terms of number of children referred. So we have some hypotheses about that and trying to address some system needs, but it has been a little unusual to get that large number of children referred.
One of the objectives of the START program is to assist individuals receiving care in the least restrictive setting, at a least costly setting, and to improve the quality of their lives in doing that. In both regions, we have found a fair amount of individuals who have accessed psychiatric services in the past, and in both of the regions following implementation of START for that individual, there's been a significant reduction in the use of psychiatric care as well as ED use, as you can see from this slide.
And this is actually very early in the process, and we will, continue to track this over time to see if what we find immediately after use of START continues. But these are very promising trends for New York.
Another component to the START program is community training, and both regions have been doing an extensive amount of that. Again, I come back and I coined the phrase earlier this week, and I think I said it earlier today, that we're here to provide service to the system as a whole. And a key part of that is not just helping deal with crisis situations for individuals, but helping to enhance the skills of the various providers across the region. And you can see from this slide some of the training that we've been providing. And we're continuing to work to enhance the training opportunities to providers across the area. We've developed catalogs. We actually have recently done a survey of various providers to see what specific training needs may best meet their needs. Another part of the training and assistance to the system is the clinical education team. The clinical education team is usually a forum that's held monthly, and through this forum we use a case presentation to provide a training to the system. So we'll identify a case that one coordinator is actively working with, and we'll use that case to kind of teach the rest of the system strategies for working with that case, but the goal is to help kind of generalize that so that when folks hear how we work through this specific individual's case, that it helps the service system begin to see ways to work with other folks from a different perspective. So again, a very important part of the model, and the CETs have been done in both regions, and generally they include representatives from the START team, including the clinical director and the medical director, who provide training through that forum, and then we invite the other stakeholders in the system, again, so that we are creating a learning environment and an educational event. So again, an important part that both teams have been able to implement. Another part of what we do is work on START action plans and assessments.
So again, as Gary mentioned, the role of the Center for START Services to come in and teach the methods and the processes that meet the fidelity to the START model. And part of that are some tools that we use, some ways we do assessment that were consistent across teams, which helps us with gathering the data. And as Gary mentioned, the data has been really important as we've gone through. These particular ones, the START action plan is a plan that's developed early in the process after referral to kind of map out and anticipate what type of supports the person is going to need over the course of their time in START. I don't know if we've mentioned this before, but when somebody is accepted into the START program, they usually receive services from START over a period of 12 to 15 months or so. So it's not a really short term in terms of just kind of crisis response. It's really continuing to work with the system. So that's why the action plan is important, as we consider that person's system and their individual needs and how they're presenting, and try to map out a plan of how we're going to work over the next few months, and we update that on a quarterly basis. The other things that are done at initial referral to START is an aberrant behavior checklist, the ABC, and that's re-administered every 6 months, and then at discharge from the program or when somebody becomes inactive. The recent stressors questionnaire is a questionnaire that's used at intake, and then again administered when there is some type of crisis in the system. And that is a real important tool for addressing some of the things we see with folks, which is that not all the presentation we see is based on just behavioral or just psychiatric, but there's lots of other things going on in that person's life. So the recent stressors questionnaire asks a lot about other things happening in terms of maybe losing a staff person, having a sibling get married and move away, things that are stressors for folks that sometimes we don't catch in the system. So again, these are tools that we use that really help inform how we move forward. And the ABC particularly has been an interest in terms of our research and using the database. Gary mentioned the SIRS. So New York START is part of SERS, but also every START program across the United States is also part of that. So it provides us a way to look across and within states to look at data and how that kind of informs how we go. So as you can see, START is really a data-informed model. So we're going to use what we learn from looking at our data to make adjustments and make sure we're addressing the needs in the community that need to be addressed.
Each and every person that's enrolled in START receives a cross-systems crisis prevention and intervention plan. It is one of the critical components of our program, and it's very different than the plans that are in place many times when we first get involved with an individual. These go beyond behavior plans. These go beyond what may be a crisis plan that a community provider has created around an individual. And they're really designed to bring a team together and get ideas about how to assist the person in helping them avoid crisis situations, and to more importantly, to truly understand the needs and vulnerabilities of the person.
Yeah, and I think this is an area where sometimes there's a little confusion around the role of this cross-systems crisis plan. But if you think about it in terms of, as Gary said, we're a provider to the system, so we're trying to work to enhance the system. So I often try to explain it in terms of the cross-systems crisis plan being for the system, while a behavior support plan, while it includes the system, is really designed for that individual. So they're different and they can complement each other. They're not the same thing. We really are what happens when we're in crisis, and what is the system, how does the system need to respond. So we're trying to give that information to everybody that's involved in that person's life. So again, we'll complement each other in terms of if that person has a behavior plan in place, we'll try to work together to make these complement each other.
There are several other components to the START program. They involve comprehensive service evaluations. Again, we spoke briefly earlier about in-home supports and crisis supports. I think the comprehensive service evaluations are something that becomes very, very helpful to a team. We've received some good feedback from even some psychiatrists that we've been working with on how detailed these reports are and how they get into all the issues that may be impacting an individual.
Yeah, so the next slide actually gives you a little bit more information about this. So you see these numbers are smaller because the CSE really is an in-depth review of the person's history, so it takes a good amount of time and effort on the part of the coordinator to gather that type of information. So they're not done on everybody that's referred. Again, based on kind of clinical necessity and particularly complex cases with medical issues or where there's history that hasn't been really looked at in a long time. So the coordinator will spend a lot of time kind of digging into that and gathering records from a long time ago until present to really kind of look and see if we've missed anything with this person. So again, kind of based on the presentation and the complexity and the need for this, some individuals receive CSEs, not everybody. Every coordinator, on the other hand, every coordinator is required in order to be certified to complete a CSE. So all coordinators will know how to conduct a CSE.
Since May of 2015, we've been providing in-home supports in Region 1, and as we build our staffing base for that, we've been able to reach more and more individuals. We have helped individuals who have essentially been housebound, unwilling to leave their home, even for medical care. We do a lot of modeling and teaching of how to interact with individuals, both for group home staff as well as for families. In-home supports can be relatively short in duration. We try to span the gap between what the individual needs and what the typical community provider can do for the individual. Again, we come in from a focus of trying to provide training to the people that are providing care to the individual, modeling, coaching, and all that through our in-home supports. And again, our numbers are growing. As I said earlier, we're beyond 26 individuals and families we've been able to serve to date. And we've been, in our 17 counties, I believe we've been able to provide in-home supports across 9 of the 17. So we're spreading out more and more with this service while we're waiting for our resource center to open. Another key component of the START program is crisis supports. And our response is to not just to the individual who may be in crisis, but to the other people in the community that may be providing care to that individual. There's times that we may go to a family home and assist in an emergency situation. We may go to a hospital where someone has already been brought in and assist both the family around the individual, as well as the caregivers in that setting to help understand what may be going on with the individual, but also to provide them support to let them know that they're not in that situation alone. And both teams have been providing a significant number of those crisis services throughout their regions. Many times we're able to resolve situations, or through working with an individual, be able to provide phone consultation before the situation has gotten too far out of hand. But there's times that we feel the need that we need to be on site to provide support to either the individual or some other crisis team that may be responding to the individual's family or home. We have a 2-hour response time that we need to provide that service for. And again, because of the huge region that we're covering, we may be going from Buffalo to Jamestown or from Canandaigua to Elmira and providing those emergency responses. And many times what we'll do is seek out other first responders that can get there quickly and help stabilize the situation until we can get to them.
So as a result of the crisis calls, we track, another part of our data is to track what happens, so what disposition is from those calls. So I won't go through all these numbers, but the ones we really like to see, and these look really nice for New York, is that kind of in the middle there's maintain current setting, and you see that's a pretty high percentage for both teams there. So that we really, that's our goal with folks, is to be able to stabilize within their setting so they don't have to go out to another setting if it's not appropriate. So that's what we're looking to see, and the data looks really good. I will say, because we've talked a lot about, you know, reducing psychiatric hospitalization, reducing ED use, and those kind of things. The other role that START has is when somebody does need a psychiatric treatment, that we actually try to help facilitate that access. So there's many times when we can avoid that and it's not needed, but I think we need to also point out there are times when somebody with IDD does have a psychiatric crisis and they need psychiatric treatment. So in those cases, we will try to facilitate that type of treatment and get access to those services. But these numbers look really great for the START teams. You guys are off to a really, really nice start.
You'll see some small percentage of individuals that do get held in emergency rooms and psychiatric EDs. But again, part of our role is to help move them back to their previous setting and to assist in that transition. That's how we can keep down the number of days they're in that crisis bed or avoid the inpatient stay. So I'll let Jill go into this. This is a key component of the START model. The pyramid.
Yeah. So if you're, like it references the public health model, so we're really basing kind of what we do on that type of thing. So we've mentioned several services we provide, and they fall within these different categories of tertiary, secondary, and primary. And tertiary is like in the medical world, you know, going to an emergency room for a medical issue, and the same thing in terms of mental health. It's when you have to access an outside service to meet your needs and you're in crisis. As you can see, the intensity of the intervention is more when you're in that set, and then the ability to have many options is lower when you're in that kind of lower tier. What START tries to do is, while they provide that tertiary intervention, they're always trying to push services up to secondary and primary. Secondary are more specialized services, doing crisis planning, using our resource center perhaps, those type of services. And then the primary is what Gary mentioned in terms of all the community training that we've done. Is we're really trying to move things up until we're doing a lot of that primary intervention and getting folks within that individual system and within their network to understand them better and really try to integrate their health and wellness and create positive experiences for them so that we reduce the reliance on some of those more secondary and tertiary interventions. So this is an important visual to think about in terms of what START is trying to do, is to always push services up to that primary intervention. I know we're getting close to our end of time. I think we've just got a couple more slides, and we can actually kind of skip over some of these. These talk about what I just talked about in terms of the...
Right. These give examples of some of the things that we do as we do interface with the treatment systems in the community. There's many, many different components, but again, a key part of this, we're going to keep talking about that, is the ability to link with the providers and work through the situations for the individual. The crisis calls and mobilization data, we talked a little bit about. This graph is a little misleading in that data is as good as the data that gets collected sometimes. Both teams respond to crisis situations for people on their current caseload, and that's one of the things we found that's needed, that we need to focus in on in order to provide the service quality that we need to provide. Should an individual be referred to us that is not a current START enrollee, we provide some assistance to the system and the providers to see what can be some ideas that we can generate to assist the immediate situation, and then see if that can be resolved. Again, some of the next steps is to continue to roll out the START model across the state. Again, all the START programs in New York as well as across the nation work collaboratively. We all learn from each other. We will be developing a statewide advisory council to bring, again, try to maintain consistency, continuity of the service across New York, and continue our reaching out to various providers in all areas of the state so that we have a true cross-system framework supporting the START teams in the various regions. We continue to work off of funds. In the very, very near future, we're going to be looking at waiver service billing, and ideally to get to a point where START services are unique billing mechanism for us. And within the OPWDD site for START are several links. You can find links both to the regional teams as well as to the Center for START Services, where there's videos and all sorts of information about what the START program has been doing nationwide and understanding more about how the program is implemented.
Thank you very much, Gary and Pam, and also Jill, for presenting the information on the START program. We do have a couple questions that came through during your presentation, and I know we're a little bit over time, but I'd like to give the opportunity to you to address the questions for a few minutes. The first question is around respite. Is not respite an integral part of the model? Can you please share a status of this piece of the program?
Right, and so that was the respite is the resource center that we mentioned, and we've avoided calling it respite. I understand the question, but we've avoided calling it respite to some degree because we want to make sure people know it's a therapeutic environment that has a lot of elements to it. But yes, it's in development here in Region 1 will be the first place that it actually has a house. I think there's a house secured. Gary can even update this, but we're just beginning renovations. Hopefully we'll start any day now. So we're hoping by fall, October maybe, that we will have the first resource center up and running in New York.
Great, thank you very much. The second question that came through, at a recent DDRO family support meeting, it was stated to families the START program is more focused for families versus providers. Can you please comment and explain a little bit about those differences between services focused on families versus focused on providers?
Yeah, that's an interesting statement in that we are here to provide services to families, but ideally, as we help the system enhance their skills and capabilities, it provides services to more and more families and individuals across the state.
But in terms of a referral coming to START, it doesn't matter whether the person's living at home with family or living in a residential setting or what. That doesn't determine who gets served through START. I think one of the focus areas, particularly in the resource center, are those planned beds, which aren't totally exclusively used by families, but we really do try to make sure we're supporting families with those planned services, but it's not by any means restricted in any way to providers, and we really want to network and work with providers. So, so yeah, the services that are provided are available pretty much to anybody. But we do, you know, there's just because we know there's a lot of folks who still have their family members living at home, we also want to make sure we support them.
Right. I believe our data right now for Region 1 is approximately 25% of the individuals served are living in some type of congregate setting, and the rest are with families.
Great. Thank you very much for providing some additional information around those questions. And I know that we went a little bit after 5 o'clock, and I do want to again thank all of the participants as well as the panel speakers for sharing some perspective on both the collaborative and the New York START program. And if you have any further questions after this webinar, please feel free to email Bakar or myself, Tricia Hertz, and we can be certain to follow up with you, and we will be sending out the slide deck as well as the recorded webinar. Thank you again to the panelists.
Thank you. You're welcome.